Welcome to this explainer. Today, we're breaking down the absolute essential, life-saving guidelines of the APIC 2026 Ebola Playbook. If you're a healthcare professional, a facility manager, or honestly just someone who wants to understand exactly how the medical frontline prepares for high-consequence diseases, you are absolutely in the right place. So let's just dive right in. We're pulling this guidance straight from the authoritative source, the 2026 Ebola Playbook, published by the Association for Professionals in Infection Control and Epidemiology. Their whole goal here is to make sure your front door is the ultimate line of defense against emerging threats. Our agenda today covers 1. The 2026 outbreak context, 2. Understanding Ebola transmission, 3. Frontline screening criteria, 4. Strict infection control measures, and 5. Care in vulnerable populations. Moving right along to Section 1, the 2026 outbreak context, Bundibugyo virus in DRC and Uganda. Okay, as of May 2026, the Bundibugyo virus is driving a very active outbreak in the Democratic Republic of the Congo and Uganda. Now, this is heavily complicated by regional conflict and massive population displacement, which, as you can imagine, makes tracking the disease incredibly difficult. And because of that, early detection and specifically preventing indoor transmission at our own facilities is absolutely essential. To put the stakes into perspective, just look at this number. While fatality rates historically bounce anywhere from 25 to 90% across previous outbreaks, the average case fatality rate sits at a very sobering 50%. Basically a coin toss. Half of those who contract the disease do not survive, which totally justifies every single strict precaution we're going to cover today. Which brings us to Section 2, Understanding Ebola Transmission, breaking down the pathogen. You know, we tend to throw around the word Ebola as a catch-all term, but it actually refers to disease caused by 4 specific viruses that infect humans. We've got the Bundibugyo virus, the Ebola virus, which is the Zaire strain, the Sudan virus, and the Thai forest virus. The current 2026 threat we're looking at is specifically driven by the Bundibugyo virus. Now, here is a fundamental, absolutely crucial rule of transmission. The virus spreads through direct contact with infected fluids, like blood or contaminated objects, like bedding or medical equipment. But, and this is a big but, it only spreads after symptoms appear. A person who is just incubating the disease isn't shedding the virus yet. That one fact is literally the biological linchpin of our entire isolation strategy. That brings us to the incubation period. On average, you're looking at 8 to 10 days after exposure before symptoms show up. However, it can stretch anywhere from 2 up to 21 days. This massive 21-day window is exactly why monitoring travelers and potential contacts for a full 3 weeks is just standard public health practice worldwide. The clinical progression is a really stark contrast. It often starts out looking a lot like the flu: sudden fever, fatigue, malaise, maybe a sore throat. But those general early symptoms can rapidly escalate into severe vomiting, diarrhea, abdominal pain, rash, and eventually impaired kidney or liver function. Catching those early symptoms before they progress is everything. Let's jump into Section 3, Frontline Screening Criteria, the first line of defense. So, your facility's screening logic has to follow these specific sequential steps. Step 1, identify epidemiological risk. Has the patient traveled recently to the DRC or Uganda, or had direct contact with an Ebola patient? If yes, move straight to Step 2. Check for clinical symptoms, like a fever over 38.0 degrees Celsius combined with a severe headache or fatigue. If both of those align, you hit Step 3. Rapidly initiate infection prevention. You do not wait. On to Section 4, Strict Infection Control Measures, Protecting the Healthcare Worker. Once a patient is identified, these strict transmission-based precautions are totally non-negotiable, especially for stopping indoor spread. We're talking standard, droplet, and contact precautions for every single interaction. Specifically, this means using face masks, face shields, fluid-resistant gowns, and gloves as your required personal protective equipment. The patient absolutely must be in a single room with a dedicated toilet. And if you're doing any aerosol-generating procedures, an airborne infection isolation room is required, along with a mandatory, strict log of every staff member who enters. It's really interesting how the CDC distinguishes between these two patient categories when figuring out PPE. For clinically stable patients who are just suspected of having Ebola, standard precautions are all that's required. So, face masks, face shields, gowns, and gloves, instead of a full PPE suite, which is heavy, hot, and resource-intensive. But if a patient becomes clinically unstable or is confirmed positive, the risk of exposure to bodily fluids skyrockets. At that point, you must immediately escalate to a full fluid-impervious PPE suite to keep the healthcare workers safe. I absolutely love this mandate because the trained observer is literally the unsung hero here. A trained observer should monitor healthcare workers during PPE donning and doffing to ensure proper technique and protection. When you're dealing with a pathogen this severe, you can't afford a single slip-up. This buddy system makes sure every piece of protective equipment is handled flawlessly. For environmental safety, the playbook is super clear. Always prioritize dedicated disposable medical equipment. Use it once, dispose of it properly. But if you absolutely have to reuse non-dedicated gear, you must make sure your disinfectants have an emerging viral pathogen claim. They have to be registered under EPA List L, which proves they can actually kill the Ebola virus. Finally, Section 5, Care and Vulnerable Populations, Supporting the Patient. This is the critical question healthcare workers are facing on the front lines right now. Without a licensed vaccine or a specific approved antiviral treatment for this exact Bundibugyo strain, how do we actually care for these patients? Well, the answer lies in early, aggressive, supportive therapy. Because we can't target the virus directly with a specific drug yet, we have to meticulously support the body's own systems. We're talking immediate fluid resuscitation, precise electrolyte management, and treating any secondary complications the second they pop up. Managing symptoms aggressively from day one is exactly what gives patients the best possible chance of survival. We also have to be acutely aware that certain special populations face a drastically heightened risk for severe outcomes. The playbook explicitly calls out children under 5, pregnant and breastfeeding individuals, and the elderly. When screening and triaging, these demographic factors require extreme urgency and care. Look, the immediate risk in our local U.S. communities remains low right now, and thankfully, no cases from this current outbreak have reached the U.S. to date. But the sheer severity of this disease means every facility has to maintain an active, ready-to-implement response plan. Whether you're a massive acute care hospital or a small walk-in clinic, preparedness is just not optional. I'll leave you with this provocative thought. Evaluate your own facility's readiness today. If a patient walked through your front door right now with a fever after traveling, are you truly prepared to identify, isolate, and safely manage them before the pathogen spreads indoors? Don't wait for an outbreak to arrive to find out the answer. Thank you for joining me for this explainer. Stay curious, stay structured, and most importantly, stay prepared.